Okay, moving on, we have paper number 21. Pedal arterial calcification is associated with progression from transmetatarsal amputation to major amputation following infrainguinal revascularization for CLTI, presented by Dr. Liu. Senior author is Dr. Vartanian from UCSF, Kaiser, and Milan, Italy.
Hi, thank you, everybody. Unfortunately, even though this is Iris Liu's work, she's a dedicated and talented O15 resident with us. She could not travel to the meeting, so I will be presenting on her behalf. Thank you. So pedal arterial calcifications are frequently incidentally noted on plain foot films in patients with CLTI. And until recently, the significance of these findings were undefined. We now know that pedal medial artery calcification is more common in patients with diabetes and end-stage renal disease, and our previous work has shown that pedal medial artery calcification scoring system, which we call PMAC, is independently associated with inadequate revascularization and with major amputation in patients with CLTI. As a quick review, the PMAC score is calculated from a 2-view minimum plain foot film on which medial artery calcification can be appreciated as linear tram track-like opacities. 5 pedal arterial segments are assessed for a total score of 0 to 5, with 1 point each for calcification in the DP, plantar, metatarsal, hallux, and non-hallux digital arteries. In this representative film, this patient has the maximum score, a PMAC of 5. Our previous work has shown that higher PMAC score is independently associated with male sex, diabetes, and end-stage renal disease. And importantly, the score itself has very low inter-observer variability. Additionally, PMAC independently stratifies risk of major amputation in patients undergoing infrainguinal revascularization, and those with high PMAC scores were less likely to have improvements in toe pressure despite technically successful revascularization. However, what is not known is if pedal artery calcification influences the outcomes of wound healing, such as a combined forefoot amputation with revascularization, obviously a common treatment paradigm in patients with CLTI. Thus, we hypothesize that PMAC burden is associated with failure of TMA healing and progression to major amputation, despite a technically successful revascularization. This was a retrospective analysis of patients who underwent TMA, combined with what we defined as a technically successful revascularization, which means the restoration of inline flow to the target artery pathway of the foot. Only the first revascularized limb was included in patients with bilateral interventions, and patients without foot films or those with prior minor amputations precluding full scoring were excluded from the analysis. PMAC scores were blindly assigned, and we dichotomized the scores as low, those having a score of 0, 1, or 2, or high, 3, 4, or 5. Our primary endpoint was TMA progression to major amputation. We identified 357 patients that met our inclusion and exclusion criteria. 93 underwent TMAs, or 26% of the cohort, and 74% underwent revascularization alone. Those who required TMA were more likely to be male and have a history of tobacco use. 54% of the cohort presented with Wi-Fi stage 4 limbs, and not surprisingly, those with higher Wi-Fi stages, including all individual component grades of the Wi-Fi score, were more likely to have undergone a TMA. PMAC scores were dichotomized as low in 48% and high in 52%, and those who underwent a TMA were more likely to have high PMAC scores. Age, diabetes, renal failure, anatomic pattern of disease, as described by the GLASS score, were not significantly associated with TMA. In a logistic multiple regression model for factors associated with TMA, male sex, Wi-Fi stage 4, and high PMAC scores were all independently associated. This is a survival analysis looking at our primary endpoint, freedom from major amputation, stratified by PMAC score. Low scores are in blue at the top, high scores are in orange at the bottom. The PMAC score was significantly associated with, in univariate analysis, with TMA progression to major amputation with a hazard ratio of 3.1 for the high compared to the low scores. Of the 93 patients who underwent TMA, 26% later underwent major amputation. Those with higher PMAC scores were more likely to have undergone major amputation, while those who went autogenous vein bypass were less likely to have undergone major amputation. There were no other significant differences in demographic, limb staging, or other anatomic characteristics analyzed. In a Cox proportional hazard multiple regression model, smoking history, high PMAC score were both independently associated with TMA failure and progression to major amputation. Autogenous vein bypass was independently associated with freedom from amputation after TMA. There are a obviously number of limitations to a study of this nature. First, this was a retrospective single-center analysis very much influenced by our own institutional practice patterns. We've already demonstrated in previous studies that high PMAC scores influences choice of endoluminal revascularization over bypass, which is also supported by the results of the study. And though we do our best to characterize the nature of those decisions, it's very difficult to fully characterize that in a retrospective manner. Nevertheless, we demonstrated that patients undergoing complex limb salvage requiring TMA, PMAC is independently associated with TMA failure and progression to major amputation. This analysis is adding to the body of work demonstrating that PMAC score is a simple and practical tool that aids in the preoperative assessment and revascularization for CLTI. Thank you.
Thank you. Greg Weston, Indiana University. I really appreciate this. I think we need better ways to assess patients with severe distal calcification. My question is, do you in your practice perform any interventions to the pedal arteries? And if so, did you examine that, the revascularization beyond the target artery and through the pedal arch?
I would say we very rarely perform below the ankle interventions. It's mostly restoration of inline flow to the foot. So it's not clear to me whether, nor do we have the data to be able to answer that question, just because we don't do very much.
Hi, Vanita Stanford. Great talk. I really appreciate this, and I agree. We already know these are really complex patients, and it's hard to know if we even should be doing them. Just a quick logistics question. Were the TMAs, do you know how they were done? Were they tension-free? Were they closed? Was there wound vac? Was there regular wound care? I mean, that kind of management obviously makes a huge impact as well. I'm just curious.
Yeah, we don't do guillotine TMAs. We close our own TMAs. I would say roughly 15% of the cohort had open TMA with secondary closure. And in those situations, it may be managed with a wound vac. And in questions where we think the perfusion is tenuous, we'll usually use a spy camera to make sure that the tension is, or the closure is tension-free.
Do you have any correlation between the PMAC score and kind of the distal runoff angio? I mean, are these patients that just have that, flow to the foot but nothing going to the toes anyway, or? Yeah, there's not many great below ankle angiographic scoring systems, certainly none that have been validated. So we have correlated that using the pedal modifier and the glass scoring system, and we haven't been able to show that makes a significant difference. I think just between what we see here and the results that we've seen with hemodynamic improvement, I think one issue is you're getting transmission of circulation to the foot, but you're not getting distribution through the tissues past these essentially end arteries. And I think one of the takeaway messages here is you really have to assess adequacy of perfusion at the tissue level. It cannot be angiographic. The tool that we use the most is a toe pressure, which I think works pretty well here. Obviously, in the setting of a TMA, there are no toes. And so I think that's, if we have to skate to where the puck is going, we just need a better way to have spatial and regional understanding of tissue perfusion after an intervention. And, the best we have right now is a TCPO2, which is obviously somewhat problematic in these types of cases.
Hi, Alex from USC. This is really great work. I want to thank you for what you've already published. We've started to look at this a little bit at our own center. My question is, you had mentioned wound healing potentially related to the PMAC. Have you looked at that or thought of looking at in any other ways besides amputation?
Yeah, so great question. We initially wanted to start with a real wound healing study, but as you imagine, it's really difficult to do a wound healing study retrospectively because the wounds are so heterogeneous in terms of area, depth, and unless you're really using a wound camera to prospectively study and measure area, it's just a hard question to answer
in a concise way in a retrospective study. So we thought studying a really clean amputation, midfoot amputation, and whether it progresses or heals, we can probably get at, but I think that kind of question would need to be answered prospectively.
Do you go straight from TMA to BKA or AKA, or do you or your orthopedic foot and ankle colleagues do any of the more aggressive midfoot?
We might do a short TMA, but we rarely will do something like we certainly won't do a Liz Frank, rarely do a show part. Usually goes from TMA to BK.
Thank you. Thanks very much.